Conference Facebook Live presentation, and I have a few messages that I'd like people to know right now as we're getting into the world of COVID-19 here in North Carolina. The first message is that I think there's a lot of kind of confusion about, hey, where are we right now? You know, I can't go to the restaurant, I can't spend any more than 10 people at church. We're doing a lot of things here in North Carolina right now, but you know, I'm not really seeing a lot of COVID-19 monsters lurking around right now. So where are we really? And so I'd like to use an analogy, so and give me a little bit of patience with this. But I think that here in North Carolina, we're all used to dealing with hurricanes. And we watch the hurricane offshore on our maps, and then we see our weathermen telling us where the hurricane's coming. And we've been doing that for the last few weeks because here in North Carolina, weather seems to be pretty good on the COVID front, nothing happening. But the hurricane's been coming across the Atlantic. So right now, the hurricane's offshore. And I think we know that the hurricane's going to come ashore, and landfall will happen here just like it has in other places in the United States. We have a little bit, though, of some good news for us here in North Carolina, is our hurricane's a little bit later than the hurricanes in other places. And so we've had time to prepare more, we've had time to think about this, and we have had time to do something that we don't get to do with hurricanes. So let me explain. When a hurricane comes ashore, we don't really know if it's going to be a category 1, 2, 3, 4, or 5. We're kind of in the same situation. But with a hurricane, there's nothing we can do about it. Mother Nature is totally in control, and it's going to come ashore whatever it wants to do. Because we've had some time to think about this and prepare, we have instituted measures through public health and community responses that maybe can help us keep the category of the hurricane at 1 or 2 instead of 4 or 5. We have all lived through category 1 or 2 hurricanes. It's annoying, it gets in the way. There's a few people who might be heavily impacted. But a 1 or 2, most of us, we don't really sweat it so much. It's the 4 or 5s that make a difference. This is why we have asked everyone to participate with us in a community response that we call social distancing. What is social distancing? It means we'll work from home for a while, if you can. Not all of us have the luxury, but a lot of us do. It means not getting together in groups. And the group has been defined as 10. And so if there's more than 10 people, it's probably not a wise idea. Why do we do this? Is because the virus spreads from person to person, usually by very close direct contact. Usually that means for us within 6 feet for more than 10 minutes to 30 minutes or so. That's where we've defined it. Really close contact, touching, hugging, hanging out at the same desk of somebody, for instance, for a while is also more of a problem than just being around them. So social distancing is designed to keep people apart some, but man, us, is a social animal. We love getting together, we love talking to people, we're social people. So it's a little bit hard to do, particularly for younger people. So that's why we've closed dining in the restaurants. That's why we have told people at churches, let's try to set up something virtually, and people are learning tech who've never had to learn tech before. And there are alternate ways that we can still interact as human beings and not have to get together in groups where we have the potential to transmit it. It's important, though, that everyone do this. if it's just, well, you know, maybe we just let the grandfathers and the grandmothers or the people who have underlying illnesses where, you know, who don't really want to get it do this, but yet all the young healthy people are still hanging out together, that's where the virus is going to transmit, and then it's still the older people and the other people who are going to end up getting it, because it's still going to go through our community. So everyone has to do it. Even me, even us here in the room, we all have to do this. It's arduous, I know it's hard, but it's really important because we all want a Category 1. We don't want a Category 5. And if we can get the virus transmission slowed down enough, it will make a difference. Do we have scientific studies to show that? We're starting to get that information from other countries who've done this, particularly in Asia. That's why you see the top doctors in the United States getting on the news conferences and telling us to do this. My next message has to do a little bit with not really understanding virus transmission here with COVID-19. So the virus is transmitted from a person who has the infection to a person who doesn't. Or it gets transmitted from a surface that the person has an infection, has got their cough droplets or something else on. Those cough droplets really are a problem only for a while. And it depends on the surface, but it can be anywhere from a few hours to maybe a day or two. If you clean that surface, soap and water, any disinfectant, Lysol, it's gone. It's dead. What doesn't transmit the infection is a contact of a contact of a contact. So let me explain. If there's a COVID-19 patient and one of their family members goes to, let's say, a school before we shut the schools down, and then one of those school people go to another place, and one of those people go to another place, but they're all fine, that does not expose you to COVID-19. You are exposed really only being around an exposed person. Most of the people who are capable of transmitting COVID-19 have symptoms. Some people, you know, the symptoms may be a little mild and they might say, you know, it could be, maybe it is, maybe it isn't, maybe I'm getting sick, so I'll just go to work or I'll just go and do my usual stuff. Those are the people who might be transmitting it. It's really not a stealth virus. It's not like COVID-19 is going to fly out from behind a tree and grab you. Okay. With proper social distancing, this should work. So the other thing I wanted to talk a little bit about is where are we right now on COVID-19? Well, as I mentioned before, I think the hurricane's offshore. And it's going to come ashore, and we're going to start seeing more and more cases. Right now, what we're seeing are little feeder bands, little thunderstorms coming ashore from the hurricane. Hey, I heard of a case here in Guilford. I heard a case in Charlotte. There's cases in Raleigh. Almost all of these cases that we know about right now that we have identified through testing have actually been imported still from other areas or have been from somebody who is known by testing positive, we've known to have the infection. So we haven't really been seeing a lot of activity of the virus kind of on the down low, stealthy under the scenes. Our emergency department visits are not up with really seriously sick people across the whole state. Our intensive care unit visits are not up across the whole state. We haven't seen any signals yet of severe respiratory infections, which is what people see in hospitals when it first hits your community. But as put out yesterday by our state epidemiologist, we do suspect there is some COVID-19 activity happening in community transmission that we don't know about that hasn't been tested yet. Probably a lot of mild people. I've actually been saying that for a couple weeks. It wouldn't surprise me if that's happening. So the hurricane's getting closer, and we're having these feeder bands of little storms coming ashore. We're going to see more cases in the next week or two, and the cases will probably double every day. Wouldn't surprise me a bit. I'm totally expecting it. One of the reasons is because we're testing more. And when you test more, you find more. So today, right now, we don't have any really severely ill people with it here. Our hospitals are not stressed because of people coming into them. We're all social distancing, and we hope to keep it the way it is right now for a while. So I was going to open it up to a few questions now, and we'll go from there and see if there's any other items. I have a few more, but I think it'd be a good time to ask questions.
So the big news, I think, yesterday was that reports show that pregnant women are in the higher risk category now. Can you talk about that?
Well, pregnant women being in the higher risk category, it is still, they are not as a higher risk as they are from influenza. And actually, it's probably pretty modest compared to other things. The big higher risk categories are having other health problems that affect your organs, such as heart disease, lung disease, kidney disease, being immunosuppressed. So having had a transplant, being on drugs that make you immunosuppressed, and things along that line. On the spectrum of risk for pregnancy, it's down here compared to all of these other things. I really don't think that pregnant women need to be doing anything different than what we're all doing anyway, right? Social distancing and keeping us apart a while. And I think if they have concerns, they can bring it up with their obstetricians. But otherwise, it's really not as high of a risk as many of the other things.
How long do you expect this to keep going?
Yeah, how long? Well, it's going to go on longer than a hurricane usually does. And there is speculation along the whole spectrum. It's going to go on longer than 2 weeks. It's going to go on longer, I think, than 4 weeks. Past that, we're getting into more speculation than we are science. So if you watch the epidemiology curves from the other heavily affected areas in the United States, what is an epidemiology curve? It is simply counting the number of cases over time. So if you look at California, Bay Area, if you look at Seattle, and if you look at New York, these epi curves look like this. For those of you who can see on the camera, it goes up and up and up. And what we want to see is it to start to peak. If you look at those areas, they have not started to peak yet. And they've all been dealing with it for 4 weeks. But these are the hot spots. Social distancing wasn't happening in those places before it was probably too late to help. The heaviest affected area right now is New York City. And do I think it'll be as bad as what it's going to be in New York here? I suspect not. But don't watch New York and think that this is going to be here. We don't know that yet. But back to your question, longer than 2 weeks, shorter than 3 months. I don't think that we're going to start to feel really normal until midsummer. And I'm not the only one who said that. Tony Fauci has said that. In the long run, we're going to be living with COVID-19 for a long time, because just like H1N1 influenza, it's going to come up at a lower level every year. So if you look at these pandemic curves, again, I'm going to use my finger, so bear with me. The first year, it's really bad, lots of cases. More and more people get immune. The next year, not as many cases because more people are immune. Immunity increases. Every year, it gets out. So the H1N1 epidemic that happened in 2009, I mean, we still have those infections every year. It's rolled into the usual flu season. But it's not yearly the numbers that it used to be. So, a little bit more to come. We in healthcare will roll COVID-19 into all of the other viruses that can cause pneumonia and think about those. I think there will be a vaccine. I think it will take some time. I'm still thinking about a year. But that is going to be the eventual solution to this.
Now, I just got pushed that the CDC data, new CDC data, shows that nearly 40% of the patients sick enough to be hospitalized were aged 20 to 54, kind of bringing light that it's not just those above 70 who are having the severest.
No, it's not. So the question is so I don't have an Apple Watch. So somebody just put out that the CDC just said 40% of people who are being hospitalized are between the ages of 20 and 50, did you say? 20 and 54. So yes, younger people can get it. And we've been saying that all along. The ones who have the hardest trouble with it, though, are the people who have serious illnesses and who are older than the ages of 65 to 70. So while some of those people are being hospitalized, it doesn't necessarily mean they're in trouble with it. The other thing you have to realize is early on when we were doing this, we were hospitalizing people who had flu-like symptoms from it until we could sort out the home isolation issues. And a lot of those people still also might have comorbidity. So a 30-year-old with severe asthma who gets hospitalized every year anyway for their asthma is different than somebody who isn't. So just to clarify, so I don't disagree with their info.
Oh, no.
Yeah.
At the end of it, it said that, but those older than 75 have more risk of dying.
Yes, over the age of 75 clearly have the most risk to dying, and our data from Seattle really show that. That in the elderly, it's particularly can be severe. That's the vulnerable group still I think we want to protect. We want to protect our grandparents. We want to protect those around us who have underlying diseases. It's just another reason to be a good citizen, patriotic, and live through the social distancing for a while.
So we've got a question, a couple questions from a reporter who couldn't be here today. So can you talk about who really needs to be tested?
Who really needs to be tested? Boy, Joe, I'm glad you asked that. So that's a big thing. So we wish that everyone could be tested. We really do, because it would be helpful, particularly in the early stages. So let's compare a little bit to influenza, and then I'll more specifically answer your question. So when we have flu season go into a community, we do a lot of testing. We want to know, is flu here? Where is flu? Who's it affecting? Which flu is it? And we do a lot of testing. And we use that testing to help guide treatment and other management of the patient since staying home. Once we know that flu is in the community, we don't test so much anymore because we just assume it's there. And when you come in to the emergency department during the middle of a big flu season and you have a fever and a cough, you have the flu. So what do? Well, we treat you, and then we tell you to go home, drink lots of fluids, take care of yourself, tell us if you get these severe symptoms, and write it out. So when you talk about who should get tested now, it's moving into a stage where the people who we're trying to save our limited number of tests for right now are, one, people who are in the emergency department and who are going to be admitted to the hospital, or people coming from a clinic who are going to be admitted to the hospital. Why? Because it helps us with our clinical decision making as doctors for those people to know what they have. Having a diagnosis is good if you have more severe infection, which means people in the hospital. It also helps us with isolation in the hospital. And as we'll talk about a little bit later, the PPE, the personal protective equipment, the gowns, the gloves, the masks and stuff, we have to conserve as much as possible. And so we want to make sure that if we know the people who have COVID-19, it helps us do that in a way to conserve that. The other group of people that's important for us to deal with in medical are people who are healthcare workers. And that's so that we can test those, because right now we need to get our healthcare workers back to work as fast as possible because of staffing things. It's really not an issue right now for staffing, but as we move in and the hurricane comes ashore, it will. So we want to make sure we can get our healthcare workers back to work who get sick. And so if we can get testing for them, that's good. Outside of that, in clinics, it's testing people where it'll make a difference. So people who you might be worried about, older people, people who have other illnesses where knowing if they have it makes a difference. People who are really at high risk for having it. Hey, I just got back from New York and I hugged 172 people and I was in a big meeting of people coughing. Those are people we would test because it's really a high likelihood they're going to have it. The last group of people are kind of people who have fever and cough. Hey, I got a cold, I got the flu. Should I be tested? Well, we're moving into a stage now. We're not really. If you're not in any of the categories that I just talked about, no, you probably don't need to be tested. So what do I do? Well, first of all, stay home, which we're all doing anyway, right? Don't let anyone come into your house who, who you're worried about could get it. I mean, we can't do that 100%, but, spouses and people like that are fine. But outside of that, probably not a good idea. And home, isolate. You know how to do it yourself. It's not hard. And how long do you do it for? Well, we now know that it's safe if you do it for at least 7 days, or you've had improvement of symptoms for 72 hours. That means your fever's gone away, you've stopped coughing, or the coughing's getting a little bit worse, but particularly your fever's gone away. Whichever is longer. So let's take some examples. I've been sick for 3 days. I'm now getting better. By day 5, I feel really good. You're still going to isolate for 7 days at home. Let's say you've been at home for 7 days and your symptoms have only been getting better for 1 day. Then you're going to wait 2 more days to make it 3. Yeah, I know it's a little bit complicated, but I think that to summarize that, if you're feeling much better, 7 days at least. If you're not better at the end of 7 days, then you can wait a couple more if you're starting to get. If you're getting worse, then you need to call your doctor. Does that answer your question? Or your question about who should get tested? Yeah.
It's the start of allergy season as well here in North Carolina. Does that complicate things with this?
Well, it complicates things a little bit for people who have an allergy, because allergies are miserable. And but for most doctors, we can sort it out because a big component of COVID-19 is fever. 85% of people now, if you put all the studies together, have a fever. Allergies don't give you a fever. Most allergies give you stuffy noses and maybe a little of postnasal drip, and sore throat. That's not COVID-19. COVID-19 is cough in the respiratory realm. So it's kind of easy to sort out, actually.
Now, say someone was to have the coronavirus, what are they supposed to do in isolation at home? Just what you mentioned. And a lot of people, I know you've reiterated this, it's not as bad. Like, the symptoms, I guess, aren't as bad as the flu in some cases, and that when you're being treated at home, it's just like a common cold, fluids. I'm just trying to say for those people who are freaking out, I have a lot of friends who are like, if I get it, am I going to die? No, that's not the case. And I know you want to talk about that.
So the question is while you're doing the home isolation, one, how do I keep from freaking out? Two is what should I be looking for? And three, what should I be doing? So I'm just summarizing because I don't think everyone can hear the questions. But so 85% of people still, that number hasn't changed. They're going to be fine. It's a mild to moderate illness. You can stay home, and it's nothing to worry about. We've been saying that all along. It's like having the flu. In fact, for a lot of people, it'll be even less than the flu. So what do you do? Well, what would I do? Let's see. I would catch up on Netflix. I would hang out, read 3 or 4 good books, and use that time to myself wisely. What would I not do is say, hey, let's have the party over at my house. Or what would I not do is say, hey, Grandma, why don't you come on over? It's a good time to visit. I'm not at work right now. Those are things I would not do. I mean, home isolation means isolation. If you have a spouse at home, it's okay that the spouse still stay there because they've already been exposed. And unless that spouse is in the category of vulnerability and much older and such. And there you can work out with your doctor over the phone how to best do that. Sometimes it involves hotels, sometimes it involves spouse moving to the other room for a week and not getting together as much. Some of it's just common sense. And then what you should be looking for is things getting worse. For the people who have severe otherwise problems, the first 5 to 7 days aren't so bad. It's between day 5 to 7 where things really start to get worse. So if you start to get short of breath, if you start to get confused, if you're so fatigued that you absolutely just even can't get out of bed, those would be things to look for. That would be something to call your doctor about, and who can then help you with that, because you might want to be evaluated at that point. But if you're otherwise doing fine and it's getting better, just like the cold or the flu does, then that's it. So it's drink lots of fluids, keep hydrated, stay with good nutrition, eat well, Uber Eats, not to promote any one company, and things like that. I mean, it's everything Mom told us to do when we're sick, when you're staying home with the flu. It's the same stuff. It's chicken soup. I love chicken soup. So.
To help with the fever, do you have any preference on especially
Yeah.
paracetamol versus
So to help with the fever, there's a lot of people who are wondering about Advil with this and saying, well, maybe Advil's not such a good idea because it does this with the virus and this and this and this. That's all test tube stuff, and I'm not sure it's really important in the long run. So whatever you use to usually reduce your fever, you can use for this. Advil, Tylenol.
And we've heard that there might be potentially 2 more cases in Forsyth County. Have you heard anything about that?
So we're going to be seeing more cases in this county as well as all of the counties around us. And I believe that our health director is having a press conference this afternoon, and he can give you the information on that. I will say, though, in generality, that the places that I think are a little bit higher on the curve, if you remember the curve goes up, plateaus, goes down. The ones that are a little bit higher on the curve here in North Carolina are not unexpectedly our major population centers, Charlotte and Raleigh area. We're a little bit lower on the curve. It's a good time to not have as many people.
How important is it to limit the number of visitors, not only here but at other hospitals?
So I know a lot of hospitals in our region have been asking that we limit the number of visitors. And really during any time when a communicable disease is going around, this is important. So we do this for flu. We do this for vomiting, flu, norovirus, and other things. So right now, most hospitals are all doing this. So what we're asking is that there only be really one essential visitor for a patient who is hospitalized. And that's so that we don't have to use as much gown and gloving either for that visitor. And so we can save those up for us as healthcare workers. And the other reason is we don't want to expose anyone unnecessarily, and so it's for their health too. But one essential visitor, I mean, that's a good idea. You know, somebody who can hang out and be in the room, help out, and so a parent can be with the child, so to speak. I wanted to also mention about children, because a lot of things people worry about kids. So it's in California right now, I think there's 700 in some cases. Don't quote me on that, but it's pretty high. Less than about 5% have been in children. In fact, the number of children you could count on two hands right now that have been identified in California. So there really is something charmed about children. We all knew that anyway, right? So that's good news for me.
And then we had a question about just the supply chain across the country.
Yeah, supply chain. So let's pick it on the things that are most important to me. Food. That's important to me. Food seems to be good. Everything that I'm hearing through the emergency networks is that the food distribution line is going fine. And that means don't hoard. Don't hoard. The toilet paper situation is totally unreasonable as far as I'm concerned. But it's the same for all food. You don't really need to be hoarding. And I'm not worried that we're going to run out of food here in the United States. That's not been an issue with any place where the epidemic's been hard. Supply chain for other important things, you might start to see get affected a little bit. And some of that has to do with where the production was. And China makes a lot, it's a big manufacturing area, and they were shut down for almost a month. They're coming up now. In fact, the epidemic has kind of run its course through there, mostly. And so their factories are restarting. So some of the stuff, the toilet paper truck is on its way somewhere between here and China. So in healthcare, the supply chain is something we have to keep a very close eye on. Because hand hygiene solution, for instance, is getting to be in short supply. I think anyone's tried to get it from Amazon knows that. That's hand sanitizer. We use that a lot in healthcare, so it's getting to be a little bit harder for us to find it. I don't think anyone's run out yet, totally. But you know what? Soap and water still works. And a 20-second hand washing is just as good as hand sanitizer. You don't have to have hand sanitizer. And I haven't heard anyone say we're going to run out of soap. So the other thing in the supply chain in healthcare that we're looking out for is gowns and gloves and masks. So far, so good. I don't know of anyone who's totally run out in this state. And I think most places are still being able to keep up with it by using some innovative things to do that. I'm not scared about us totally running out of that. But the more we can conserve, the better we'll be. And one thing, again, to help us with that is by testing people who really need it. The last thing is testing. The tests themselves are done right now at the Public Health Laboratory in Raleigh. Most hospitals have the capability of doing them now, either through doing them in their own hospital, and that's about 4 or 5 of them, or doing it by sending it to large commercial laboratories. And there's 2 major ones in North Carolina we use. So we have a way to get the test actually run. The turnaround time is a little bit longer still, just because there's a lot more going. There are the thing in testing that we're running out of is actually the swabs that have to be used to do the test, and then the media that we use to transport it to the laboratory. Viruses basically need their own little Kool-Aid, because if we just send a swab, the virus doesn't make it. It needs a nutritionist Kool-Aid, Gatorade, in order for it to get to the laboratory. And then there's a very special swab you have to use, because just any cotton swab won't work, like a Q-tip. We have to use a special thing called a Dacron swab. Those are the two things for us right now in this area that are limited and are limiting some our testing abilities. I am confident that we can test everyone that needs to be tested, like we talked about earlier, those people. But if we start testing everybody who has a runny nose, a cold, a sore throat, we're going to run out of those things right now anyway. So that's why we're trying to test the people where it really makes a difference. Some places are setting up places to test in tents. And that's okay. And those are places where they have a need to have one place to do the tests, because their outlying clinics and facilities don't have that capability so much. Some hospitals have chosen not to do the tents yet, because we're being able to do it with the usual doctors we usually use. As time goes on, you might see more people using tents just because it's easier. It doesn't have to do with, hey, I'm worried I should get tested. Lastly, and I didn't say it earlier, if you are not sick, if you have no symptoms of fever or cough, you don't need a test. Because it's not predictive. If you have no symptoms and you get tested, if it's negative, it doesn't mean you won't get COVID-19. If you don't have symptoms and you get a test done and you're positive, it doesn't mean you'll go on to get it. So if you don't have symptoms, we still say don't get tested unless you've been told specifically by a public health entity that it would be important to do. It's just not predictive of the disease if you have no symptoms.
Everybody good?
Happy. Thank you.
All right, Facebook Live friends, thank you. All of my friends and family members watching, hello.